بسم الله الرحمن الرحيم. زملاء الأعزاء جراحين الصدر، هنبدأ النهاردة إن شاء الله أول محاضرة من محاضرات الكورس، وهنتكلم فيها عن clinical evaluation and thoracic surgery overall. نتكلم عن history taking examination, symptoms و signs. Our area of interest is thoracic surgery. دايما symptoms و signs بتكروس أو overlap ما بين cardiac origin أو pulmonary origin أو chest والميدياستاينم والأمور ديت. مهم جدا ان احنا نقدر نحط differential diagnosis، وده اللي هنتعلمه ان شاء الله. من المهم جدا انك يبقى عندك المهارة للaccurate clinical assessment including the history taking, general examination, local examination و system based symptoms and signs تكون محطوطة خريطة كويسة في ذهنك. لما نقول الهيستوري تيكينج بنقابل العيان غالبا بيكون عنده chief complaint أحد الحاجات اللي قدامنا ديت: الكف، الديسنيا، chest pain، الهورسنس أو dysphagia، weight loss وفيفر fatigue، عنده history of trauma، عنده recurrent infection. الكف طبعا بنبدأ onset course duration, nature, sputum or not, dry or wet, associated with hemoptysis, degree of hemoptysis starting from mucus streak up to massive hemoptysis. Dyspnea again started with onset, course, duration, severity, associated with orthopnea, paroxysmal nocturnal dyspnea, what aggravate, what decrease, and so on. Chest pain, pleuritic, likely increased by movement of respiratory cycle, constant, nature, dull aching, and so on. Radiation, hoarseness, which is a change in the voice, mostly due to airway or vocal cord problem, or recurrent laryngeal nerve problem, dysphagia associated with masses in the mediastinum, or disease in the esophagus itself, or neurological insult as we see in the course, weight loss and fever and fatigue, trauma history, and recurrent infection. So here, to start by history taking, I would focus on past history, family, and social history. For past history, I would to emphasize about surgical history, in scars in chest wall, mediastinal entry from median sternotomy, TB, COPD, cancer, thoracic surgeries. Again, as regard of family history, in a lung cancer, genetic conditions like Marfan, and so on. So social history, very great importance about smoking, alcohol in Western countries, mostly occupational or environmental exposure, like in mining or coaling or asbestos exposure. Vital signs: temperature, pulse, regular rate, blood pressure, respiratory rate, and saturation. We'll add saturation by pulse oximetry. General appearance like cyanosis or not, clubbing, degree of clubbing, edema, cachexia, weight loss overall, unintentional. Okay, so other signs: lymphadenopathy, generalized or localized for the neck or axilla or inguinal, palpable or not, or radiologically detected. Skin changes, facial swelling like superior vena cava syndrome, skin changes like paraneoplastic syndrome in small cell lung cancer. Chest examination, inspection, percussion, palpation, auscultation. By inspection, assess for chest symmetry and wall chest wall deformity. Use of accessory muscle. This emphasize about patient distress or not. Trachea position, deviated or shifted, retracted, centralized or not, visible swelling or scars, and chest wall movement again. For palpation, I would to palpate trachea first, neck for lymph nodes, trachea, chest expansion, tactile vocal parameters, tenderness or masses, or something like that. So percussion, a resonance, it's normal. Dullness, what's the cause? Effusion, consolidation, fibrosis, hyperresonance, mostly due to pneumothorax. Auscultation, breathe sounds, vesicular or bronchial breathing or absent. Vesicular is normal, bronchial in consolidation, absent overall like in pneumothorax or effusion. Added sounds like wheezes, crackles, pleural rub in pleurisy, crackles in pulmonary edema, wheezes in COPD and bronchial asthma, vocal resonance change like in consolidation. Here I would start pulmonary symptoms and signs. Symptoms: cough, hemoptysis, dyspnea, fever, weight loss. Signs: like crackles, wheezes, decreased breath sounds again, and clubbing. Pleural symptoms and signs: pleuritic chest pain, dyspnea, and dry cough. This patient will express himself in this category. Signs in dullness, decreased breath sounds, and pleural rub again. Okay. For mediastinal symptoms and signs, mostly hoarseness, dysphagia, orthopnea, chest fullness, signs, neck vein engorgement, enlarged face, tracheal chest, Horner syndrome, if affecting T1. Severe symptoms, mostly dysphagia or dinophagia, regurgitation, weight loss, signs aspiration, malnutrition, and halitosis, like in cases of Zinker diverticulum. Chest wall and diaphragm, venous swelling, tenderness, masses, paradoxical movement. Airway and trachea symptoms, again, stridor, dyspnea, voice changes, stridor like tracheal tug, cyanosis, and prolonged inspiration. Emergency condition دي تتعامل بشكل سريع. Need rapid attention, and dealing with this condition in emergency department. Don't exhaust the patient in unusual examination or history taking or something. And we are lucky in all literature, this category need rapid management without extra unnecessary investigation, like even chest X-ray, like condition tension pneumothorax, tracheal chest, and hypotension at the absent breath sounds, massive pneumothorax, shock and dullness on percussion, in addition to collapsed neck veins or in congested neck veins in cases of tension, cardiac tamponade, Bixi triad, which is distant or muffled heart sound, shock, and congested neck veins. Hearing embolism, sudden dyspnea, altered consciousness. History and examination are vital. Regional and systemic evaluation guides diagnosis. Recognizing emergencies is critical. And thank you very much.